Hi, my name is Kelly Benabou. I'm a minimally invasive gynecologic specialist here at Baystate Health, and it is my pleasure to have this discussion about fibroids with you tonight. I have no disclosures. So this is an outline of what we're going to discuss tonight. What are fibroids? Who is affected by fibroids? Symptoms and diagnoses of fibroids, treatment options, and how do I see a specialist? So fibroids are abnormal growths that form in the uterine muscle wall. They can be located in the uterine cavity, in the middle layer, or protruding from the outer layer of the uterus. Fibroids are not a form of cancer, so many of you may have heard growth or tumor, and those words can be very concerning because we use them in the context of other things that are related to cancers. So fibroids in themselves are not a type of cancer. The other name that you may have heard is leiomyoma, and that's just the big name for fibroids. And their growth is typically driven by hormones, and particularly estrogen. So I'll go back to this, but the main concept is that fibroids have estrogen receptors that respond to estrogen. So who is affected by this? So approximately 1 out of 4 to 5 patients will develop uterine fibroids, up to 70% of patients by age 50. And about a quarter of the patients presenting with fibroids are actually symptomatic. So there are many patients who have fibroids who don't really have symptoms. Black and Asian Chinese patients are disproportionately affected compared to white and Hispanic Latinx patients with a 2 to 3-fold higher risk of developing fibroids. And unfortunately, our data is still limited on other racial groups. There are ongoing studies looking specifically. So family history certainly poses a risk towards development of fibroids, particularly in young patients. Other factors include higher body mass index or BMI, vitamin D deficiency, early onset of periods, and a diet that is low in fruits and vegetables and high in consumption of red meat. So heavy bleeding is one of the main symptoms that is caused by fibroids. There are many other causes of heavy bleeding, so that alone cannot be assumed to be due to fibroids. Sometimes it's difficult to know whether or not what you're experiencing is considered normal or heavy. Patients get told from an early age that what they're experiencing is normal, and many patients come to me saying, I've just been told to deal with it from a young age. But normal bleeding is actually equivalent to about 2 to 3 tablespoons per cycle. And not that everyone's measuring their cycles in tablespoons, but it just gives you a sense of how little that's supposed to be. Abnormal bleeding is characterized by soaking through pads or tampons every 1 to 2 hours while you're having your period and passing large clots. So what are regular periods? So normal periods come every 21 to 35 days, and that certainly varies from person to person. Having fibroids can change the length of the menstrual cycle and cause irregularity. So even if the cycle falls within the 21 to 35 days that I'm telling you, if it varies from month to month by 7 to 9 days, from cycle to cycle, that's still a sign of an irregular period. So just being within that range does not mean that you're regular if the timing is different every month. So most patients have a hard time with remembering those things, and certainly nowadays, the phone makes it very easy to track. If you have a smartphone and you're able to download one of the many apps that exist for tracking menstrual cycle, I have some of the more popular ones there on a slide for you. Most of them, all of these, have a free version and a paid version. The free version is plenty to characterize a period, so you do not need to spend money on these. You do have to have a smartphone though. And then there are old school charts that you can print out that will help to, you can write in menstrual cycle to menstrual cycle to figure out if what you're experiencing is normal or not. And I have an example there from the National Bleeding Disorders Foundation, just giving you a sense of what the pad or tampon is supposed to look like, depending on how much bleeding you're having. And then you basically add the number of points to figure out if what you're experiencing isn't within the normal range or if it's abnormal. The next symptom that I would like to cover is pain, pressure, or fullness. So this is due to the bulkiness of the fibroids, and it depends on their size and position. Fibroids can compress the bladder, the bowel, or other vital structures, including blood vessels, ureters, which are the tubes that connect the kidneys to the bladder. And so all of these things can end up with symptoms such as like urinary frequency or feeling like you have to go to the bathroom a lot, or having issues going to the bathroom and having bowel movements, or the opposite, having a lot of inflammation that's caused by the fibroids and having loose stools. It can also be a cause of back pain. So back pain is a very complex topic. There are many reasons, again, why someone can have back pain, but certainly big fibroids can be part of the problem. Bloating or feeling abdominal protrusion, depending on how large the fibroids are. And then by shifting the bowels, they can lead to feeling full after eating a small amount of food or early satiety. Pain can be exacerbated by a process called fibroid degeneration. This happens when fibroids outgrow their blood supply, causing the cells in the inside to die. This may cause fibroids to shrink in size, but usually causes worsening symptoms for a few weeks and then improves over time once that process sort of progresses. Not everyone that has fibroids will experience this, but it is a complication of having fibroids. It can also lead to heavier bleeding, and the inflammatory response that it causes can lead to fevers and lab abnormalities related to the inflammation. So it's one of those things that if you know you have fibroids and you're experiencing sort of an acute on chronic pain, it is worth talking about it with your healthcare provider. There's imaging that can help identify this as well as blood work. And then the last thing I'll talk about in terms of symptoms is subfertility or infertility and early miscarriages. So unfortunately, there are many causes of both of those things. And having fibroids alone doesn't mean that a person will be infertile or have miscarriages. But certainly certain types of fibroids, especially the ones affecting the uterine cavity, can lead to a risk for infertility and for pregnancy complications. So certainly it's something that if someone is having a hard time with becoming pregnant and they see their healthcare provider, part of the investigation is to look for fibroids and other causes of infertility. So let's shift gears to diagnosis of fibroids. So typically, any of the previously mentioned symptoms should trigger your provider to perform an exam. Sometimes fibroids can be palpated on an abdominal exam, depending on how large they are. Pelvic exams allow for easier identification of enlarged uterus. Not every provider is going to perform a pelvic exam, but they may send you to someone who will. Blood work is frequently performed for a workup of heavy bleeding, including complete blood count to rule out anemia and other labs, such as looking at the thyroid, other causes of heavy bleeding. And if heavy bleeding is occurring, depending on the patient's age and risk factors, the provider may recommend an endometrial biopsy. So an endometrial biopsy or uterine lining biopsy is not a biopsy of the fibroid. It's a biopsy of that lining, which I'll go back just to show. So the sort of where you see that number 0, 1, or 2. So within the cavity of the uterus. And this is because the most common type of cell abnormality in the setting of heavy bleeding is actually either an overgrowth of the cells of the lining of the uterus, which can be precancerous, or a uterine cancer. And so there's some overlap in symptoms, and therefore the part of the workup is to exclude other things that can be causing heavy bleeding. This can be performed in the office or as a procedure in the operating room with sedation, and certainly as a discussion with your healthcare provider. Imaging is crucial for the diagnosis and for fibroid mapping. So to develop a map of the fibroids, we will typically send patients for a pelvic ultrasound and an MRI may be ordered depending on the findings and depending on the plan. I've been telling up to now that fibroids are not cancerous, and that is true. But there is a type of cancer that can grow in fibroids, which is called leiomyosarcoma. It is an incredibly rare cancer. It occurs in about 3 to 7 in 100,000 patients. There are risk factors that sort of raise our suspicion for this. So patients who are older than 60, postmenopausal status, tamoxifen use, which is a medication that's given to patients with certain types of breast cancer, history of pelvic radiation, a history of childhood retinoblastoma, and a condition called hereditary leiomyomatosis and renal cell carcinoma. It's sort of beyond the scope of this talk, and I'm happy to talk more about this if people are interested. But patients with known conditions such as these and presenting with fibroids should sort of be at a different suspicion level for potentially having this rare type of cancer. Since fibroids cannot be biopsied preoperatively, this is usually a diagnosis from specimen that's removed during the surgery and sent to pathology. So in order to risk stratify patients, meaning to figure out if you are at a higher risk of this being the case or a lower risk, we will often send patients for an MRI. So I talked about the ultrasound being the first thing, but the MRI would be something that potentially would show more detail of the fibroids. It could be a better study to identify this, or at least to raise suspicion of that this may be the case. And then blood work to test for things called tumor markers. And although these tests are not diagnostic, they certainly help to raise or lower the suspicion. So it's what we have in terms of available resources to try to risk stratify and do the proceed with the correct surgery or treatment option for these patients. So next, we're going to talk about options for treating fibroids. So considerations to be factored into the decision-making include age, since fibroids typically start to shrink and symptoms improve after menopause, whether or not patients are planning on a future pregnancy, fertility preservation, and associated conditions such as anemia, and size, number, and location of fibroids. So combined estrogen, progesterone, contraceptives or oral contraceptives are the most common type of medical therapy used for patients with fibroids. This therapy will not decrease fibroid size. However, it will help with bleeding. The selection of whether someone is on pills, a vaginal ring that contains the same components, or a transdermal patch is driven by patient preference in regards to dosing and frequency of use. In addition, patients really should be screened for whether they're appropriate candidates for estrogen use in particular. There are pills that contain progesterone only and are safer for a certain class of patients who have any other conditions that may be contraindicated for estrogen use. Now, I've told you earlier in the talk that fibroids are driven, their growth is driven by estrogen. There's still some debate, but there's a thought decades ago that birth control pills that contain estrogen could actually cause fibroids to grow. Nowadays, with the low dose pills that we use, there really hasn't been any evidence of that in the literature. And in studies looking at patients who use this, it is considered actually first-line therapy for bleeding. So it's something that, you know, I hear and see all the time in the office. My patients come in saying, I used to take this and I was told to stop because it's actually making my fibroid grow. And sometimes it is really what was helping them with bleeding. And so just a note that I would like for patients to know, to question it if it comes up. And then there are also hormone-containing IUDs or intrauterine devices that can be used to help with bleeding, and that's certainly a patient preference thing. Sometimes patients don't want devices and inserted, and that's I completely respect that choice, but it is a good choice for many patients. And the only class of medications that's really known to help with shrinking the fibroids is called gonadotropin-releasing hormone receptor modulators. Big name, GnRH agonists or antagonists. These medications are usually temporarily used for 6 to 12 months. They can be used for longer, but usually up to a year, given significant side effects. And, I'll mention one big thing that we are always careful with is these medications, they basically induce a temporary menopause, or they cause the ovaries to stop producing hormones. And one of the consequences of that is potential bone loss, so thinning of the bone density, and that's, as far as we know, reversible, as long as, again, it's not a prolonged period of time, but it's sort of a scary thing to end up with another problem, such as osteopenia or osteoporosis, which is low bone density. And we have ways to monitor for that, but that is one of the limitations of how long we can use this medication for. The other symptom is hot flashes and night sweats, which is what you would expect to get if you are in menopause. So it's very similar to that, and there's certainly things that we can do to try to improve the symptom and the side effect profile of these meds. They're great medications, not always well tolerated, but used in the right setting can help quite a bit. Unfortunately, once of these medications, the last one I mentioned, is stopped, there's a chance for the fibroid to grow again. And so it's often used before surgery or preoperatively to try to achieve a certain size of fibroids, to change modality of surgery. That's a very frequent use for these meds. And then there's a non-hormonal option for patients that certainly can help with bleeding. It's called tranexamic acid, and it helps to prevent breakdown of blood clots. It can only be taken up to 5 days during a month. And so during the period, patients will take it for up to 5 days. So if your period is 7 to 9 days, you can only take it for the first 5. But there are patients who, again, swear by this, and it is a very effective way of treating the bleeding, but does not affect fibroid size. So in terms of procedures and surgeries for premenopausal patients who do not desire future fertility, uterine fibroid or uterine artery embolization is a minimally invasive option for management of fibroid-related symptoms. Up to 90% of patients will report improvement. So whether that's a decrease in fibroid size, not necessarily, but at least with bleeding. And it can shrink fibroids up to 50% of their initial volume. So depending on the size of the fibroid, it will either shrink it down to a level where both bulk symptoms and bleeding is improved, or bleeding is improved, but potentially still having bulk symptoms if, let's say, it's a very large fibroid. The fibroid's the size of a watermelon, and now it's down to a size of a grapefruit. You may still have bulk symptoms even if the bleeding is better. And again, it's sort of depending on the patient and what their preferences are. That may be enough to provide relief, and it may be what they're looking for. It's not typically recommended for patients desiring future fertility, even though it's a uterine sparing technique, because it affects the blood supply to the uterus. So just don't have a lot of data suggesting that it's safe, and it could be associated with pregnancy complications. Certainly, patients have become pregnant after having this procedure and had normal pregnancies, but it's just preemptively, if we can avoid that's better. The next thing I want to mention is a newer technology called focused ultrasound surgery or radiofrequency ablation. These are procedures that cause tissue softening and shrinkage over time. So that it has that sort of big name. Coagulative necrosis is the tissue softening. It's similar to uterine artery embolization in terms of efficacy. You will shrink fibroids up to 30 to 50% of their initial volume. As you see there, there's sort of an ideal patient with, not too many fibroids and the size being limited. Just because of the way that this works, the efficacy would be much lower if the fibroids were bigger or if there were a lot of them. This is a newer technology, so there's still studies ongoing, but there's promising data in regards to safety in future pregnancies. Myomectomy is a type of surgery to remove fibroids while sparing the uterus. Selection of mode of myomectomy, so whether it's done in a minimally invasive fashion, laparoscopically, or open technique, is determined by the number, the size of fibroids, the location of the fibroids, and either modality does not appear to impact pregnancy outcomes as far as we know. There are comparative studies as the rate of new fibroid formation is fairly high following a uterine sparing intervention, such as a myomectomy. So up to 40% of patients who have the surgery will eventually have another fibroid. And certainly that risk will decrease over time. But if, let's say, a young patient has a myomectomy, their chances of developing another fibroid into their 30s is almost a third. So fibroids are removed ideally close to the time where someone would be actively trying to pursue pregnancy to avoid that new growth. I also mentioned their hysteroscopic myomectomy, a lot of big names. So this type of myomectomy, or removing the fibroid, is reserved for fibroids that are within the cavity of the uterus, the ones that we talked about potentially affecting fertility. So it's often a procedure that's done as part of infertility treatments, to remove the fibroids. There are no skin incisions. It is done under anesthesia, transvaginally, and very effective, quick recovery. And then a hysterectomy, which most of you know what it entails, but it's considered the definitive management for fibroids. And the reason why is because of the zero risk of recurrence after surgery. It can be performed in various ways, for instance, sparing the cervix and or the ovaries. And this is decided based on the reason for the hysterectomy. So fibroids alone are not a reason to take ovaries out. Not necessarily a reason for taking the cervix out. So that, again, that is a conversation about goals and your age and risk factors and what surgery should be done. There are different incisions that we use to perform a hysterectomy. The first picture there, you can see the horizontal incision is a C-section style scar versus a vertical midline, which is the black line. And certainly it does not need to extend above the belly button. That depends on the size of the uterus, but it is in that direction. And then minimally invasive surgery on the right, you can see, is performed with 3 to 5 small incisions, and the uterus can be removed vaginally. There is a type of minimally invasive surgery called single site. So as the name says, it's a one incision, single site surgery. And again, certain people are trained to do the surgery that way. Certainly it's a surgery that can be done for fibroids. It's a little more challenging. And so not everyone will do it that way, but it's an option depending on how large the uterus is. And when possible, the minimally invasive approach is preferred, given faster recovery and lower rates of complications such as infections. So I've just been talking about, fibroids, enlarging the uterus, and minimally invasive surgery being the best approach. So you may be asking, how do you get a big fibroid out of a small incision? And so typically when we use these little incisions on the right, we use the instruments through those incisions to detach the uterus and any other parts that are being removed. And then vaginally, we insert a bag. And I have a couple of pictures there just demonstrating the different types of contained tissue extraction bags. The organs to be removed get placed inside of the bag. And then this allows the surgeon to piecemeal the tissue, so making the tissue smaller. within the bag. And that is done a little bit differently nowadays. So nowadays we use a bag. And the reason for that is assuming that there may be something bad inside of the uterus, which I just told you, right? Not too long ago, we were talking about how I really can't diagnose, exclude a malignancy completely until everything gets sent to pathology. So this assumes that there may be some abnormal cells inside of the uterus, and this way we're preventing spread of whatever is abnormal to the rest of the body. So all the piecemealing that we do is all in a contained fashion inside of the bag, and then the bag comes out with the specimen. So now you may be asking, yourself, is there a more natural way to treat fibroids? I just gave you different medications. Many of them are hormones. Many patients don't tolerate hormones. We talked about different procedures ranging from less invasive to more invasive. So is there anything else that we can do? And the answer is probably. Unfortunately, we don't have great evidence to vouch for any of these things, but there are studies, and I think more of a push nowadays to try to identify some of the supplements and some of the things that we can do that are a little bit more natural than what we just talked about. So they're promising studies showing that vitamin D3, especially for patients who are deficient in vitamin D. So if you have your levels checked and that those are low, in particular, replacing it in that circumstance has been shown to be good for prevention and treatment of fibroids. And there are different dosages, so I wouldn't attempt to give you a dose because it depends on how deficient you are. And if you're not deficient, then you shouldn't be taking large amounts of vitamin D because that also can have consequences. So it's something that certainly is worth talking to your healthcare provider, potentially getting that level checked. Being in New England certainly is a risk factor. We don't see the sunlight as much as some other places, and many patients are deficient, so it's something worth getting tested for. There's some things that really haven't shown. So vitamin C and vitamin E supplementation have really not shown to be effective, and the jury's still up on vitamin A, probiotics, and selenium. The other two very promising supplements are green tea extract and turmeric, and some patients are on this for different reasons. But the main theme is that fibroids cause a lot of inflammation and are driven by inflammation, and many of these are anti-inflammatory. So in a very basic, general way, decreasing inflammation will help with hopefully treating the fibroid. Now, I can't promise you that taking this is going to make the fibroid go away completely, but I think if you're trying to find a way to modify your supplementation or your diet, these would be good areas to focus on to make sure that you're getting ample of. And again, it's a balance. Overdoing with any of these things can have side effects and consequences. So just something to keep in mind. And then, what can make fibroids worse? We kind of talked about this in the beginning. So a diet that's low in fruits and vegetables and antioxidants and fibers, any type of synthetic chemicals that disrupt the estrogen, progesterone receptor production can lead to the increase in not just predisposition of fibroids, but growth of fibroids and heavy metals. Some of these things, obviously, we have more control of than others, but just something to keep in mind about our exposures. And then is observation an option? So that really depends on what's going on. I listed there's some things that may drive us to think, maybe doing a procedure or being on a medication right now is not the best. Because again, everything that we do has potential risks associated. So we have to really balance the pros and the cons of everything. But if someone isn't symptomatic, so they're not having any of the symptoms I listed, if they're immediately attempting pregnancy and have a conversation with their obstetrician, a gynecologist, and the fibroid does not appear to be something that would endanger their pregnancy, it may be difficult to start on medications that are birth control. or have a procedure that may delay the time to conception. So sometimes these patients are good candidates for observation. And by observation, I don't mean ignoring the fibroids, but observing. So doing serial ultrasounds or imaging studies or exams to ensure that the fibroids aren't growing. So that's sort of the next thing I have listed there. So with lesions that are stable in size, demonstrated by serial imaging for a longer period of time, so 1 to 2 years. Patients who are perimenopausal or postmenopausal are going to have lower levels of estrogen and progesterone, and most of the time when that happens, fibroids tend to shrink. Not for every patient, unfortunately, but for many patients. And then if, in general, the fibroids are not big enough to cause compression of vital organs, it is generally reasonable to monitor as long as it's not affecting the quality of life. So how do I see a specialist? You talk to your healthcare provider. Oftentimes, PCPs are the first line people that are seeing you for all your problems and mentioning to them your symptoms. If you don't have an OBGYN, and certainly if you have an OBGYN, talking to them about your symptoms and concerns. Many will order some of the workup that we talked about and then refer you to a specialist to conclude the workup and finalize the plan. So I'm particular, this is about half of my practice. I'm always happy to see patients for fibroids. I am not the only one at Baystate. Basically, all of our division would be happy department would be happy to see patients. I put there my information. So I am with Baystate Urogynecology, and that is my phone and fax number for providers. And then we have a GYN navigator whose name is on the slide, Layla Hashim, who does a lot of the triaging. And so I'm just going to leave this slide up for 15 seconds in case people want to take the numbers down. And again, I'm happy to share this. And then just some fibroid resources from our society, our professional societies. There's a ton of information online and very good information. Patient testimonials, really powerful information for patients, not just for information, but also for support. But there's also a lot of misinformation. So I like to give the sort of our society websites just so that you have some more objective information, and then certainly finding support groups. I really love when patients find that support system and come with information that they get from the groups. So I absolutely encourage that. And then these are my references. And thank you so much for listening to our discussion about fibroids, and I welcome any questions.
Thank you, Dr. Benabou. That was a great talk. I appreciate that great presentation and the resources. That was good. There's also a question in the survey if anyone needs help with appointments too. I'll help with that. So there are some questions in the queue. And I'll start with the first one. What happens to degenerated fibroid?
Yeah, so that's an excellent question. So typically, most fibroids will actually go through that process if they are present for a long period of time. And what happens is the fibroid, if it continues to grow, it will outgrow its blood supply. And then the inner part of the fibroid stops growing. It can't grow anymore because it doesn't have access. And so, for lack of a better way of describing it, those cells start to die and then cause a lot of inflammation. That inflammation over time, it's limited, so it will stop. It's not the degenerative process is not something that will usually last a long period of time. It's not in itself necessarily dangerous. It is a very painful process. Many patients have to get admitted and be on pain medication, so it can be something that has to be managed even in the hospital. But in itself is usually not a dangerous process, although it produces a lot of inflammation. And over time, if anything, it can actually decrease the size of the fibroids and maybe part of the body trying to shrink the fibroids. But that's an excellent question. I hope that answers your question.
Thank you. The next question. Why can't fibroids be biopsied or preoperatively?
Yeah, it's such a terrific question, and a question that we get all the time in the office. So there's no way to, because of the way the fibroids basically a ball of muscle, and it's in an area of the uterus that's not accessible other than there are other parts of the body that can be biopsied more easily, and a biopsy requires being able to place a needle inside of whatever you're trying to biopsy and aspirate cells. And because of how solid that process is, there's no way to biopsy it. Now, you may think, okay, so why can't you just take a chunk of it? And part of the problem is, the uterus is a very vascularized organ. And so if you did that, it would cause bleeding. So it's not something that can really be done without doing surgery. The other concern is that if, God forbid, there is something malignant or bad, then by doing the biopsy, you're actually allowing those cells not to spread. So it is a very complex issue. It would be amazing if we had a way to do it, because it would sort of bypass a lot of what we try to do, and hopefully be able to select the correct surgery for patients or the correct management. But it's not something that we can do now. I mentioned the biopsy of the lining of the uterus, and sometimes if you have an abnormality of the fibroid, it will translate into that biopsy being abnormal, but it's not something we can count on. So it's something that we do, and certainly about 30% of the time you can see a fibroid abnormality show up in the endometrial biopsy, but it's not a guarantee. So having that biopsy be negative, per se, it's not a complete reassurance, at least from that perspective. What it does provide is some reassurance that the cause of the bleeding is not an abnormal growth or cancer of the lining of the uterus, which is a much more common type of cancer. So it's still an important step, especially if you're trying to determine what type of surgery, and I mean specifically a myomectomy versus a hysterectomy, because if there was an abnormality inside of the uterus, a myomectomy, just removing the fibroids, would not be a good surgery. The reason why is, again, we are cutting into the uterus to take that fibroid out. And if there's something inside that is not good, and not something that we want to get to the outside, that could potentially happen. So that process is we try to mitigate that risk. And we do as much as we can preoperatively to make sure that we are doing the correct surgery. But it's a lot of presumptions, unfortunately. Again, I hope that answers that question.
Oh, that was a great answer. Thank you. How does the ultrasound procedure soften tissue?
Yeah, so it heats up the. So there are two current types of procedures being offered, and I'll just say that at Baystate we're trying to get the technology. And Dr. Tim Fisher, I'll just put a plug, is someone who just joined our department and was doing these procedures where he came from, and is hoping to bring that procedure to Baystate. So it may be something that we're able to offer in the future. Currently, those are offered in Boston, New York, Connecticut, so not quite in this area, unfortunately. And they're done in a couple of different ways. One is a laparoscopic procedure. So it's a procedure with small incisions. So you have to undergo anesthesia. You have to have a couple of little incisions placed. And then the ultrasound probe is placed inside of the fibroid. And it causes the internal part of the fibroid. It's sort of the same process that degeneration would do. So it causes the inside of the fibroid to die off, and causes the fibroid to shrink. So that's how it changes the quality of the tissue and causes the tissue to sort of degenerate on its own. It's a similar concept with the next procedure that I'm about to explain. It's a procedure where also under anesthesia, but no abdominal incisions. So it's similar to if anyone has had a transvaginal ultrasound or an ultrasound done with a vaginal probe, it would be a similar concept to that. And in the same concept of inserting the ultrasound into the fibroid specifically. And so these work better for fibroids that are facing the cavity, because that's how we would have access versus other fibroids, if they kind of outgrow from the uterus, then this might not reach. So that's how that is determined, which procedure would make the most sense based on the type of fibroid and the number of fibroids. But it causes the same process. So it's this coagulative necrosis, which is basically a death of the inner part of the fibroid, causing so the fibroid to potentially shrink. These are obviously fantastic procedures, but also similar to uterine artery embolization. Typically, the shrinkage that you're looking at is up to 50%, unfortunately. So if it's a smaller fibroid, that may be enough to cause symptom relief and to help with bleeding. But depending on how big the fibroid is, you still may end up with, bleeding relief, but not really bulk relief.
Excellent. Thank you. You give good descriptions. I can really understand
I
the
try.
process. No, you really do. The next question, what's an example of endocrine disruptive chemical source?
Yeah, I mean, the easiest thing to think of is there's a lot of stuff in plastics and plastic materials, and that's come up a lot more recently. They're all big, giant names that I won't even attempt to mention. But plastics tend to have chemicals that can cause different hormones in your body to go away. And there are a lot of these things are used in the industrial setting, and so there are materials at home, and so it's worth kind of Googling this and seeing what things I have at home can have this. Processed dairy, like there's a way of processing foods that also can end up having some of these chemicals. So it's sort of one of those things, and people are much more savvy about looking at labels and looking at what potentially could be in your food. But if you see a big, large name and you have no idea what it means, it's worth Googling it and or whatever search engine you want to use to figure out, where this is coming from and what potential detriment it can have to the body. So it's a complex question. We are surrounded by things that can cause this without really having a lot of control, unfortunately. But there are some things that we can control, like bottled water is an example. And a lot of companies now will say that like their bottles are BPA free, or so there's certainly more awareness to that, and I think trying to avoid some of these things, but it's very much in our society. So it's good to be mindful of it.
Yeah, excellent tip, and you're so right. Next question is tranexamic exam.
It's a hard word. Tranexamic acid.
Acid covered by insurance. In my head, I said it right.
I know these are all really tough words. So the short answer is most likely. Oftentimes we have to fill out prior authorizations for insurance companies to cover these medications to show that why someone can't be on a first line medication. This is a very useful medication in other settings. So it's not a medication that's just used for periods, but it's used for other things, for bleeding during surgery. There are definitely other applications of it. So it's not a new medication, but it's new for this. And so the commercial name is Listetta. And so you may have heard that before. Tranexamic acid is just the generic. But I would say usually we do not have a problem getting the medicine covered, but it may be something that requires a prior authorization, unfortunately.
Very good. Next question. Could you end up with a degenerative ultrasound impacted fibroid?
So like if you had many fibroids, that they would all degenerate. I'm guessing that's the question. Yeah. Yes, you could have many degenerated fibroids. Usually when that happens, typically the patient is so symptomatic that it requires management. So oftentimes that will push someone towards surgery. And once that process is happening, sometimes some of the other procedures that we talked about that don't include removing are not sufficient to help with the pain. And so that can certainly be the case. I'll tell you one specific scenario where that can happen, and it's a little tricky because you can't do much about it surgically, is during pregnancy. So if someone gets pregnant, with the hormones from pregnancy, fibroids can actually grow. So it's not uncommon while someone is getting monitored for, with ultrasounds to look at the baby, that fibroids are picked up, and over time they're felt to grow. And because that growth is a little faster in pregnancy, sometimes because of the hormones, that process can happen, which is really unfortunate. And that is not a time where we can do surgery. So, I can say personally that I've had to admit patients in the hospital for pain control in that setting. It is not usually a process that's dangerous for the baby, but it's very painful for the parents. So that's just a kind of an extreme situation of it. But if this happens sort of outside of pregnancy, typically it tends to drive patients to towards procedure, surgical management, because again, it's so uncomfortable. And there's really not, unfortunately, certainly medications to help with inflammation. NSAIDs are helpful in pain control, but there's no medication other than Lupron or a GnRH agonist antagonist, or the oral versions of it, which is the medication I was talking about before, trying to shrink the fibroid. That can potentially be used, but other than that, it's really we're being driven towards a procedure, probably to either get rid of the fibroid or get rid of the uterus.
Well, thank you for that answer. The next question, it looks like this is the last one, so just going to point out to anyone who has any questions to populate those in the Q&A box.
Amanda, thank you for all your good questions.
Are there any foods to be avoided?
Yeah, so I mentioned this briefly, but it's basically foods that are low in fiber, low in antioxidants, meats. So red meat tends to have, it tends to not, frequent red meat may not be the best for patients with fibroids, because the oxidants, so the opposite of antioxidants in meat, can potentially cause inflammation. It's a very generic answer, but it basically is, someone who doesn't have a well-balanced diet with fruits and vegetables and low in red meat and, low in fiber. So you're not, if you're not getting grains and other food products that have higher fiber, you may end up exacerbating the situation. And again, I don't know that we have exact numbers. Like if you don't eat a certain amount, then your fibroid will grow by X amount. But it's just sort of, a lot of it is correlation studies. So looking at people's diets and whether their fibroids are worse or not. And there's decent evidence showing that definitely diet, what you eat, affects your body entirely, including your uterus. So.
Excellent. Thank you. Good to know. Next question. At this point, or at this time in the world, what's considered an early onset period?
Yeah, so typically, the average is 11 to 13. And so earlier than that would be a little early. And then menarche, which is the onset of period later than 13, 14, is a little later. But because there are a lot of exposure to different things that affect our hormones, like we were talking about before, I would say there are many patients now, younger patients, having periods earlier. So when I see single digits for age, I think of early onset.
Oh, wow. Thank you. It looks like that we've come to the end of those excellent questions. And so I just we'll just give it another pulse, but I want to say thank you for this great presentation. I learned a lot about fibroids. I want to thank the audience for joining us, for Amanda for great questions, and for you, Dr. Benabou, for your time and expertise tonight. We appreciate you.
Thank you so much. I really enjoy my time. And again, thank you for your attention and for all the questions.